Hello everyone, welcome back to Karan Academy. My name is Karan and today we're going to be talking about hemorrhoids and other perianal conditions. I want to preface this by saying this is a huge warning for anyone who might be eating food. Please stop watching. There are a lot of pictures that might be quite unappetizing, so proceed with caution, please. What conditions will we be covering? So hemorrhoids, fissures, fistulas, and then a few rarer ones like pilonidal sinuses, Pruritus Ani, warts, and then cancers. So what are hemorrhoids firstly? So hemorrhoids are dilated submucosal vessels, which may be asymptomatic, but in most cases can also be associated with things like rectal bleeding, pain, discomfort, and tenesmus. Now, important to note that the rectal bleeding with hemorrhoids is quite superficial. So your typical history would say that there wasn't really blood in my stool, but when I wiped, there was blood on the toilet paper. Why do you get hemorrhoids? So you get hemorrhoids because of all that increased intra-abdominal pressure and straining. So things like straining, damage to connective tissue disease, so connective tissue diseases, which would compromise the membrane itself, as well as pregnancy. And hemorrhoids can either be internal or external, depending on whether they're above or below the dentate line. And we grade them based on their degree of prolapse outside the cavity, as well as their tendency to bleed. And we have a few pictures here. So you have grade 1, 2, 3, and 4. Everything up to grade 3, we usually treat them conservatively. So this is like your kind of your compressive kind of balloons to sit on to reduce the pressure, dietary changes, stool softness, and so on. Some forms of 3 and 4 we usually want to treat more aggressively because they are unlikely to regress otherwise. And we might consider things like band ligation, where we just string a loop of string a band around this and then tightened up, and that would eventually fall off. That's called band ligation, or hemorrhoidectomy, where we surgically just excise the hemorrhoid. Now, when we talk about liver cirrhosis in our hepatobiliary series, we talk about anorectal varices that are a common complication of liver cirrhosis. I want you to really realize that hemorrhoids are not the same as anorectal varices, although the two terms are often used interchangeably. And I'm very much guilty of this because going back to my presentations from last year, I went through them and I saw that I actually said that they are the same thing, and I was wrong in saying that. They are not the same thing. So don't make that mistake. Now, what are anal fissures? So anal fissures are tears, basically, of the anal canal. They are distal to the dentate line, and most of them happen due to local trauma. So as you can see, this is an anal fissure. So they don't always present with like a nice cut. You can also have kind of an indurated surface membrane, as you can see here. Most of them lie at the posterior commissure, or the 6 o'clock position. So if you were to be looking at the anus, it will be at the 6 o'clock position. They can also be secondary to other conditions which actually result in long-term damage to that connective tissue. So things like IBD, previous anal surgery, or even malignancy, where you have compromise of the membrane. These are awfully painful and can often bleed with defecation. So how do you differentiate between fissures and hemorrhoids? Well, obviously the two look different, but in terms of your history, one would tend to be way more painful than the other. So even wiping with an anal fissure is apparently very painful. We treat these conservatively with stool softeners, again, diet changes, and then we can also apply topical creams that can be soothing. What is an anal abscess? An anal abscess is an infection of the perianal area. So what is happening here? So you start off with an outpouching. So this outpouching can either be, it's usually idiopathic, but things like Crohn's, diverticuli, or even colorectal cancer. And obviously those would be almost on the inner surface. That outpouching can again lead to fecal matter being stuck there. That leads to a local infection or an abscess and presents with the red hot painful mass, as you can see here. It doesn't look pretty. In most cases, these are perianal, so it's next to the anal opening, but in some cases can also be ischiorectal and intersphincteric. The intersphincteric one obviously means between the two sphincters, so typically here, but in most cases it's perianal. Now these are really bad because they are so notorious for just not getting better. And we treat them by surgically excising and draining them, and then following it up with a salt bath type called a Silt's bath. That's apparently meant to help with symptoms. However, these are really bad because they don't resolve well. And when they don't resolve, the most common complication will be a fistula. And 50% of these abscesses usually tend to progress to a fistula. That's not a very good treatment outcome, desired outcome rate, is it? Now, as you know, a fistula is a connection between two areas. So in terms of anal fistulas, this can be of a few types. Basically, it's a connection between the inside and the outside that shouldn't really exist. So what happens is you have the abscess to begin with. Over time, that eats away at both ends and leads to a connection between the two. It is treated usually with a fistulotomy and a set-on placement. Now, what is a set-on? Set-on is basically a special wire that can be inserted through this fistula, so it comes out each end. And now the question is, well, why do you need a wire? Before that, let me just say that fistulotomies are better used for lower tract lesions and set-on and fiber glue for upper tract. Let me explain why that is the case. So why can't we just like close this up? Well, that technically is a fistulotomy, right? However, what often happens is that these infections still tend to be purulent and have stuff draining out of them. And obviously, unless you redirect the stool elsewhere, it's still going to be infested with bacteria. And therefore, closing it up doesn't actually have great outcomes. So when you have these long fistulas, what we want to do is we want to place a wire through them, which is called a set-on, so that they can keep draining and keep healing and kind of prevent an acute abscess brewing up again. And therefore, for these longer ones, it's good to use a set-on because the risk of an abscess is greater. But with these lower ones, you can do a fistulotomy. Now, there are a few types based on the Park system of classification. I don't think you need to know this in particular. It basically depends on the involvement with the external anal sphincter. So you can have, firstly, something like a transsphincteric where it goes through the sphincter. You can have a superficial where it doesn't go through the sphincter, as you can see. Then you have a transsphincteric here, an extrasphincteric that goes above. You have a suprasphincteric and an intersphincteric. Again, I don't think you need to know the subtypes, but these are just the different types. And I've already talked a bit about why I use a set-on. But what is important to know is where do you place the set-on? So when you see a fistula, you only see one opening. You never see the other end. You don't know where the other end is coming out, right? And to identify and figure that out, we have something called Goodsall's rule. I almost blanked for a second. And sorry, here's just a representation of what that set-on is, right? So to prevent another abscess, we just put this thread in, and that's what it looks like. And that's, again, to allow for drainage well. Goodsall's rule basically is this figure that helps us figure out the internal position or the internal opening of an anal fistula, depending on the external opening. So let's say if this is the anus, you have the transverse anal line. Depending on whether the external opening is above it or below it would determine where the internal opening is. So if it's above it, it's just this radial line going in. If it's below it, it's often more so this curved opening up at the posterior commissure. Not super high yield, but good to know Goodsall's rule. Now, what's a pilonidal sinus? A pilonidal sinus is an infected sinus found in the sacrococcygeal region. How is it different to an abscess? It's usually less severe compared to an abscess. The etiology is quite different and doesn't involve the perianal space. So what's going on here? Why do you get these? We don't exactly know why, but one possible gross explanation is that as you walk around, you have hair that falls from your head kind of into your arse crack, and that eventually kind of gets entangled there, gets pushed into the skin, that creates a sinus, and that gets infected. That leads to the pilonidal sinus, and kind of that's what it looks like, and it's full of hair. It's more commonly seen in males in their 20s with poor hygiene, and is notorious for having poor outcomes. and therefore we treat it by cutting through it and draining it, and that's called the keratoconus procedure. You can also perform an endoscopic pilonidal sinus treatment called Abcess, and that's what it would look like to firstly incise, drain, and then stitch it back up to prevent that from happening again. Pruritus Ani is simply itching and redness of the perianal region, which can be due to firstly fecal incontinence leading to seepage, and that's going to cause low-grade chronic inflammation. You can have skin breakage, parasitic infections causing itching, and lastly, excessive cleaning. That's going to be obviously physical and kind of mechanical trauma-ish. You would manage that conservatively by wiping gently, using wet wipes. You can use creams and also avoid long-term steroids because that can make the skin really brittle and thin and predispose it to tears and inflammation. That's what it looks like. So the pink kind of lacerated membrane is what the Pruritus Ani exactly is. Next, we have anal warts. Now, anal warts are mostly sexually transmitted, but this doesn't have to be through anal intercourse. They're mostly linked to HPV, so HPV 6 and 11 particularly, and symptoms include things like itching, bleeding, mucinous discharge, and tenesmus. Now, tenesmus is important because it's a symptom also of rectal cancers, and basically what's going on with these is when you have a wart that's inside the anal cavity, it kind of creates the sensation that there is stool that you want to pass, but there obviously isn't stool there. It's just the actual physical thing. And if they're small and external, you can use topical 5-FU imiquimod therapy or cryotherapy. But if they are larger, then you want to usually go for surgery in those cases. As you can see, you have a prolapsed wart, and it also has a lot of mucinous discharge and a bit of perianal erythema as well. Now, lastly, we have anal intraepithelial neoplasias and squamous cell carcinomas. So AIN is strongly linked to the HPV subtypes and is a precursor for SCCs. Depending on the depth of invasion, it can either be AIN 1, 2, or 3. AIN 1 is where you have dysplasia of just the lower third. AIN 2 is lower 2/3, and then AIN 3 is full thickness. And that has a 10 to 15 risk of progressing on to an SCC. And that's what you can see here. So we look for the skin change and for the kind of loss of contour that you can see here. They're usually treated with topical 5-FU therapy, and types 3 specifically are very unlikely to regress on their own. If you have a cancer, which is this, and as you can see, that does not look pretty at all. That looks quite nasty. You want to firstly do something called a clock ring biopsy, where you take a bit of biopsy at 12 spots all around the anal opening, so you can get a very good representation of that. You then want to do a staging CT MRI looking for metastatic spread, and then finally surgery and chemoradiation therapy. And I think that's just a very basic, like biopsy plus staging plus surgery plus minus chemoradiotherapy could be your answer to every single cancer. So I guess it's one of those things that you can just say in an endoscopy if you're not particularly sure. And that's all we had for perianal conditions. I hope that helped. As always, if you have any questions, feel free to send me a message or an email. And as always, please look after yourself and please look after your loved ones.